Okay, so Dr. O'Connell, on behalf of the Paediatric Dysphagia and Feeding, Eating, Drinking and Swallowing SIG, I want to say thanks very much to you for giving us your time. Basically, what we're doing today is we have an interview with you to try to pull apart some of the information that we might want about respiratory health and about the impact of aspiration on the lungs. So for some of the people in our audience, they will work in hospital environments where they have access to respiratory consultants all the time. They're part of their everyday MDT. And then for other members of the audience, they may never have had any interaction with a respiratory consultant, and probably the most senior in terms of the medical team and in terms of the environment will be the GP managing the child that they're looking after. So obviously all of the people here, what we do have in common is that we all work in the area of feeding, eating, drinking and swallowing in paediatrics, neonates, basically any child between birth and 18 years. So that's kind of our demographic. So what I wanted to kind of say to you first of all was that even our own education around how aspiration affects respiratory health is pretty minimal in our training, and there's very little CPD available for us kind of access through speech and language therapy. If we were to get any further CPD, it would actually be through the kind of through your channels, through kind of respiratory channels, and then that's probably too much in detail and probably maybe a little above and beyond what we want. So I'm hoping that today we might be able to get a bit of a hybrid of what we need from speech and language therapy's point of view, but obviously what you bring in terms of your specialism as well. So I have told everybody that your specialism is actually in adults and not in paediatrics, so we appreciate that you're taking a leap of faith into the world of peds today, but I'm hoping that there's enough similarities between both areas of practice that we'll be able to get some useful information. So I suppose my first question for you has come from somebody on the SIG. We asked them if they wanted to put some questions together, and really it was about if you're able to make any differentiation for us between a viral chest infection that the common general population will suffer from, and a child who may, or an adult in fact, who would have a bacterial infection as a result of aspiration. Is there anything specific about the difference, about how the pathophysiology of that presents, or the impact on the lungs, etc.?
Being honest, it's extremely difficult distinguishing between viral and bacterial exacerbations, and probably coming from an adult population, they've done studies on people coming in with asthma and COPD exacerbations, and some studies would suggest 25% are aspiration related, 25% bacterial, 25% viral and 25% other. And again, the literature on this can be skewed immensely in different places. In terms of viral, you often talk about a viral prodrome. So people can have a flu-like illness. They can be coryzal, meaning they have a runny nose, kind of eye symptoms, a bit of iritis, and kind of general viral prodrome illness. Bacterial infections per se often cause a more classic pulmonary infiltrate. We often talk about lobar pulmonary infiltrates on chest x-rays, so you think that might be associated with bacterial. Both types of infections cause high temperatures, both cause malaise. Per se, bacterial infections are more likely to cause rigors. Rigors are where there's overall shivering and shaking of the body, and that's to do with kind of thermal regulation from the hypothalamus. But it can be extremely difficult being categorical in your distinction of a bacterial from a viral exacerbation. Again, there's lots of different serum markers. CRP, procalcitonin is coming into vogue more, particularly in North America, but again, most of these are not categorical, and you often end up treating people for bacterial infections when there's any element of doubt.
So, and actually that's interesting you should say that, because our experience is the opposite. So we would often have children who we're concerned are likely aspirators, or there might be something in their underlying condition that would maybe raise red flags for us around the fact that we have to kind of monitor them in terms of their chest status, and that they're presenting over and over again with chest infections that are being put down as being viral, particularly if it's at that time of the year, we'll say, between kind of October and February, and they're presenting to the GP on a number of occasions with chest infections, but that, that basically is the diagnosis that's given, and we have some suspicion that perhaps these are bacterial infections hiding out as viral infections because of the time of the year. So what we kind of take as a gross measure of the difference is that when a GP will tell us that they hear kind of diffuse changes in the lung fields as opposed to focal changes, is that an accurate enough distinction, or is that something we could rely on, or to what extent could we rely on that as a differential?
I think it's actually quite a difficult question. So first of all, again, more coming from an adult background, often you hear people saying I've got a weak immune system, and to a pulmonary physician, that's not what you're thinking. You don't ever generally think. There are rare immune deficiency syndromes, but more frequently people that get recurrent chest infections tend to have bronchospasm and wheeze. Now, we're starting to learn more and more that childhood exposure to certain viruses such as human rhinovirus group C actually seem to embed inside in the airway mucosa, and that can predispose to adult tendencies after the age of 3. So often, as you say, you get viral exacerbations in early childhood, and in and of itself that can change the airway lining and make you predisposed to recurrent chest infections, wheeze and bronchospasm in the future. And if that becomes serial and sequential, then they will often be subsequently labelled as asthma, but in the early childhood they're not labelled as asthma. Bronchospasm and wheeze, which is where you listen and hear changes in both sides of the lungs, is a manifestation of anti-irritant to the lungs. So you can get that with viral, or you can get it with bacterial, or you can get it with aspiration related changes. So per se, I would say the prodrome leading up to it and the pattern of an exacerbation in its entirety, meaning the start, the middle, and how it resolves, is often one of the predictors. You can subsequently or retrospectively say, actually, on balance, that sounds like an aspiration. On balance, that sounds like a viral, or on balance, that was clearly a bacterial infection. But during the initiation of the event, I think it's very difficult to distinguish.
Okay. So we have a magic number that we run by, that basically you're allowed, in inverted commas, to have around 3 respiratory infections a year that wouldn't tend to raise any red flags, and that after 3 infections, we start to think that maybe there's more to it. Is that reasonable? Do you think, is that a reasonable rule of thumb, or do you think we need to be a little bit more careful about how we generalise in that regard?
I think that sounds reasonable for an early paediatric population, and then as children grow older, you probably, again, it depends on if there's classic viral prodrome truths to an exacerbation versus if there's severe bacterial pneumonias. You'll obviously be thinking of, am I missing something else rare here that's going on? There's lots of rarity things, so I always think as a consultant, your job is to outrule rare things and be left with treating common things, because you're going to get caught out if you don't assume the rarities are there. So you have to do all the tests if you're seeing a specialist, but in general, most things don't turn out to be rarities. They tend out to be the common things.
Great.